Hi, this is David, and in this tutorial I'm going to talk about the way we could monitor a fetus in utero. And I'm going to sort of conflate or put together things that are used for intrapartum monitoring, which means monitoring during labor and delivery, and antepartum monitoring, and I'll sort of smush them together a little bit. And I'll also talk about things that you monitor for things that you monitor for looking for chronic growth problems such as IUGR or intrauterine growth restriction, but as well as things that monitor for more acute events such as acute insufficiency to the placenta that could cause, or acute insufficiency to the fetus via the placenta that could cause anoxia or ischemia or acidosis. So I'm conflating a lot of things together. And I just want to say outright at the front, I don't necessarily believe that chronic insufficiency and acute insufficiency are necessarily a continuum. Sometimes they're a continuum, and sometimes they're two totally different things. But I think it's important. It's very hard to be entirely and utterly organized in every way and serve something up with complete and consummate organization. And I trust the viewer will be able to deconstruct and reconstruct and ultimately create their own chronological or whatever organization both suits them. Rather, I want to present as much information as possible, and I'll try and clarify things, as I'm going on. Some of it in a linear or discursive fashion, some of it more circularly, but this will require some input from the viewer to ultimately reconstruct their own narrative with their own sense of organization. So the first monitoring type of mechanism, or the first monitoring process that I'll mention is something called maternal uterine artery Doppler measurements. And where that's done is, as it said, on the maternal uterine artery Doppler. And the reason I put that as number one is because it's a very early sign that something could be going wrong in the pregnancy. If you look at the literature, it's not that sensitive and it's not that specific, but it's better than nothing. It's still quite good. And it's, as it said, it's a maternal indicator. So it's clearly looking at the maternal side of the supply equation. And it's looking for high resistances in the maternal circulation. And to cut to the chase, what it's a sign of is poor placentation, or in other words, poor spiral artery remodeling, that makes it hard for the mother to supply blood to the placenta at high conductances and low resistances, and therefore the resistance in the maternal tree that's supplying the maternal space of blood in the placenta shows higher resistances. So to go back to our diagram, if we look here, so you can see there's clearly two circulations. There's the fetus with his circulation, his or her circulation, and then the mother supplies blood to the space around the villi that's shown with the stippled orange, the so-called intervillous space. And that's accomplished by these cells that I've shown in green, these extravillous trophoblast cells, remodeling or changing the topology of this maternal spiral artery here. And so these cells remodel it and allow blood to come out at high conductance and low resistance into this space. And there's obviously a flux in and flux out, and that's the maternal portion of the exchange. So one of the earliest things that could go wrong in a pregnancy is insufficient remodeling of these spiral arteries that lead to insufficient maternal supply, so in other words, maternal underperfusion. And that's felt to be caused by poor migration and remodeling by these extravillous trophoblast cells that are said to be so important in remodeling the maternal spiral arteries. And that leads to chronic maternal underperfusion. And that could actually, and what that actually leads to often is intrauterine growth restriction, and it could lead to a small placenta. And it's sort of a chronic insufficiency. That would cause chronic maternal underperfusion, and it's a very, very early event. It probably actually occurs in the embryonic era. In other words, the first 8 weeks of development or the first 10 weeks of gestational age, because as you know, the gestational age is counted 2 weeks later than development because it starts from the date of the last menstrual period, not the date of conception itself. So, once again, the pathology here, or the pathobiology, is improper spiral artery remodeling, and what you get is high resistances going this way, propagating in the maternal vessel, and not enough supply or underperfusion going into this space, the intervillous space. There's not enough supply, and that pressure, it propagates, so from these spiral arteries going backwards to the maternal vessels that are ultimately supplying them, which are the uterine arteries, and the resistances in the uterine arteries then become high. So we could measure that very, very early on, even in the first trimester. And the way we measure flow using an ultrasound machine is using Doppler technology, which I won't go into now. But what the Doppler gives you is a waveform, and the waveform is really flow velocities. And so what you base, and the other thing that you need to know every time you look at a Doppler flow, you need to know that the human cardiac cycle, it's cyclical. It's not a continuous pump, it's a cyclical pump. And when the pump is on, we call it systole, and when the pump is off, we call that diastole. But there should be enough energy from systole that blood continues to flow forward during diastole. So you literally see something like this. Whoosh, 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 whoosh. So first the flow of systole, whoosh, whoosh, and then during diastole, the second flow. But as the resistances start to go up, we start to see changes. And one of the things that happens is the systolic peak has to go higher. And then the other thing that starts to happen is the diastolic flow becomes less, because the energy is dissipated more by trying to pump blood through the high resistance. So we see this in the mother in cases of improper spiral artery remodeling. We see abnormal uterine artery Dopplers, and that's an early feature. And what it predicts is IUGR, so it's a diagnostic feature, or at least it helps predict who might have a diagnostic of IUGR, intrauterine growth restriction. In other words, it helps stratify early pregnancies that are set up for IUGR. And the specific pathobiology it's looking for is chronic maternal underperfusion. So that's test number 1. And that could be done as early as the first trimester. The second test that I want to discuss with you, and I'm just going through a bunch of tests. So the first test is to literally take a Doppler and measure the mother's uterine artery. You find the uterine artery and measure the flow in it with a Doppler. The second test is you literally measure growth parameters in the fetus. So here's the fetus, and you look at the fetus and you measure various growth parameters. So you can measure the head circumference of the fetus, the abdominal circumference of the fetus, the foot length of the fetus, and you plot the growth on a chart. And we have normalized charts that show what growth in the 90th percentile would be, and growth in the 10th percentile or 5th percentile, and we define growth below the 10th or 5th percentile as small for gestational age. So just plotting and following fetal growth on growth ultrasounds that you could start doing around 20 weeks and then continue doing them forward, or even earlier, around 18 weeks, and looking where the fetal growth parameters are, including abdominal circumference, head circumference, foot length, you get a sense that the baby is small for gestational age. And if the baby is small for gestational age due to maternal underperfusion, you could call that intrauterine growth restriction, because the baby is actually being restricted. This is a pathological state. This is just an observation. SGA, small for gestational age, just means the baby's small. Okay, well, I'll tell you now. There's two main reasons a baby could be small. The baby could just be small because the baby is constitutionally small, because, some people are just small just by the normal, spectrum of human growth, by the bell curve. So that's called a constitutionally small baby. But some babies are truly growth restricted. They're not getting enough maternal flow, and therefore there's not enough flow to the placenta, and the babies are actually growth restricted. And doing this, abdominal circumference, head circumference, plotting growth will not tell you if it's small for gestational age or truly growth restricted. You need to see more abnormalities. So fetal growth is a good thing to measure. It's an ultrasound measure. It could be a sign of placental insufficiency, but it could also just be a sign of a constitutionally small baby, and you need other features. So that's what this monitoring is. And it's accomplished just by a regular routine ultrasound without Dopplers, and you could start doing them around 18 weeks, and then depending on what your concern is, you could do follow-up and plot. So that's the second test measurement that I wanted to talk about. So both of these that we spoke about so far are things that help the doctor find out if the baby has basically chronic growth restriction that's usually due to chronic maternal underperfusion, but it could be due to other things, but it would be things with chronic pathology that impair placental function in a chronic way. They don't cause acute and sudden complete placental dysfunction. They cause a certain amount of imperfection, that the placenta isn't working at full capacity. It doesn't cut it off. It's not cutting off the tap. It's just that the flow in the tap isn't great. Okay, so that's fetal growth. The third monitoring parameter I want to talk to you about is uterine artery Dopplers. And remember we spoke about, it's very, very similar. Remember we spoke about measuring resistance, or getting indices of resistance in the maternal circulatory tree. So too you could do that in the fetal circulatory tree. So where you would measure that now is in the umbilical artery. And the umbilical artery is how the baby supplies blood to the placenta. So if we review the fetal circulatory system briefly, the baby sends deoxygenated blood that comes down for the brain, not shown here, that comes into the heart via the superior vena cava, and then that goes through the foramen ovale and mainly into the left ventricle and is pumped down into the descending aorta and comes out through two umbilical arteries, but here we're going to show it as one, and runs in the placenta. And that's the supply to the placenta. The blood goes through the placenta, several orders of branching vessels, from larger vessels that run in a place called the chorionic plate, that plunge into the placental disc and split and split and split until it gets to the capillary level, which occurs down here. And then gas exchange occurs with some mother. And then blood returns ultimately via, shown here in red, the umbilical vein. And the umbilical vein returns blood to the fetal heart. And then that goes via the inferior vena cava and goes pumped mainly by the right ventricle up to the baby's brain, because the baby really wants to protect his brain, and so the oxygenated blood that comes back from the placenta is preferentially going to the brain, and it goes into the aortic arch, and then into the brachiocephalic vessels, and up to the various end targets, arteries that supply the brain, such as here, shown here, the middle cerebral artery, which that's sort of important for later. So, now, in the continuum of abnormal spiral artery remodeling, and this is important, in the continuum of abnormal spiral artery remodeling, so the mother has underperfused, what happens then is that the baby's villi grow wrong. And I discussed that a little bit in the prior tutorial, and we don't really know exactly why, but and it's not fully sorted out. It's something that I think about a lot. In the context of maternal underperfusion, the change in the villus growth, such that the resistance in the fetal tree, and don't forget the fetal tree is not touching, the fetal blood doesn't touch maternal blood. It's not direct causality. It's as if you could imagine the mother is a rain. Because of the rain is not enough, therefore the tree, which is, you can imagine, the fetal parts of the placenta, the soil's not good, so the tree doesn't grow quite right, so now there's increased resistance within the fetal tree. And what you start to see then is, if you look at the umbilical artery and you do Dopplers, and you could do it through the mother's tummy, you do Dopplers on the fetal flow in the umbilical artery, you see abnormal waveforms that indicate higher resistances. And so, if this is normal, systole, diastole in the baby circulation, you start to get higher systoles, and lower diastoles, and that shows up in things that we call like systolic to diastolic ratio and peak systolic velocity, and ultimately, if things get really bad, the resistance could be so high that you could actually get non-flow during diastole and eventually even reversal of flow, where the blood is going forwards in the umbilical artery during systole and actually going backwards in diastole. Below the line means backwards. And that's what they call reversed end diastolic flow. And so let me just sort of explain this to you. This, to me, in my concept, is not acute pathology. It is progressive pathology. So it's the IUGR, because of the improper spiral artery remodeling, that then leads to impaired fetal growth, this pattern that, for example, that we could call distal villus hypoplasia, abnormal villi, that then cause increased resistance in the fetal tree, in the fetal vascular tree. And that, in and of itself, increased resistance in the fetal tree, is what separates SGA from IUGR. Because once there's increased resistance, that's pathology, that's bad. So it's not just a small baby, it's actually a baby who's clearly being underperfused. So that this is really cool, because now I've just told you that by measuring uterine artery Dopplers, now you have a test that'll distinguish SGA from IUGR. So you do your ultrasound growth to find out if the baby is small, but then if you have abnormalities in your Dopplers, you'll know if it's pathologically small or just constitutionally small, because if there's abnormalities in the Dopplers, then that suggests that something is malgrown. And we presume it's malgrown because that's the response to the maternal, in turn, the response to the maternal underperfusion. So for many years, we considered the uterine artery Dopplers what distinguishes small for gestational age from IUGR. But the pathology could become quite progressive, so that you could actually get AEDF, abnormal end diastolic flow, where you basically have no flow in diastole in the fetal circulation, and then even reversed. And once I said, even though this is not really an acute event, it's not like something suddenly separated or something prolapsed, it's something that develops over time, still, it's acute in its imminence for fetal injury. So it's progressive pathology. It's not pathology of sudden onset, what we're looking for, increased resistance as within the fetal tree. But the consequences could be quite dire, and so it becomes acute in the sense that it becomes urgent. So it's progressive chronic pathology that reaches a point of urgency. I wouldn't say acuity, it reaches a point of urgency. And when you know you do that is when you have abnormalities of diastolic flow, because those resistances, those high resistances, are so bad for the baby's heart. The baby's heart here, that's trying to pump through these high resistances, really is suffering, and the baby could actually die. And so the rate of fetal stillbirths is very high if you have AEDF or REDF, and so there's very recommendations if the baby is mature enough, like 30 to 34 weeks, depending, and I won't get into the nitty-gritty, you would actually deliver the baby. You'd give Celestone and to help progress maturity, and you would deliver the baby. So uterine artery Dopplers are important, and they're important in two ways. One, they show you high resistances in the fetal tree, early features that help distinguish SGA from IUGR, and they also show progressive features that suggest that something more imminent or more urgent or more severe could be happening. The next parameter I want to talk to you about is this thing called middle cerebral artery Dopplers and even cerebroplacental ratio. And I won't belabor this point too much, but basically, the bottom line is this. If you rely only on abnormalities in the uterine artery Doppler to distinguish SGA versus IUGR, you'll miss some IUGRs. Because it takes a while for there to be enough abnormal growth down here in the distal part of the tree to start seeing high resistances here, up here in the umbilical artery. So it's not the world's most sensitive measure. It takes a while. So if the baby is small, even if the umbilical artery, it turns out, we just learned this recently, even if the umbilical artery Dopplers are normal, it could still be that there is maternal underperfusion, and that there's abnormality here. It's just we can't see it using this specific measure, using the uterine artery Doppler. So one major principle in fetal growth that the baby does, if the baby doesn't have enough oxygenated blood, what the baby will do is preferentially give what it has to the brain at the expense of the body. And so what you start to see is decreased resistances. Now, not increased. Remember, we spoke for a long time about increased resistances. Now we're talking about decrease. You start seeing decreased resistances in the vessels that supply the brain, such as the middle cerebral artery, and mildly increased resistances in arteries such as the umbilical artery and other arteries, for example, the arteries that supply the kidneys or whatever. And that's why, by the way, if you notice that often in IUGR, because of this brain-sparing phenomenon, it's what we call asymmetric IUGR, where the head size of the baby is spared but the body is small. And so you could start to pick that up in a rather sensitive way by looking at the resistance of the middle cerebral artery, which should be low, versus the resistance of the umbilical artery, which would be high, and taking the ratio, and that increases your sensitivity. And so now we have a better way of distinguishing SGA from IUGR, and we'll pick up more IUGRs, because by taking the ratio we increase our sensitivity. And so that test is either looking at MCA Dopplers, and even MCA Dopplers over uterine artery, not uterine, over umbilical artery Dopplers, and that's called the cerebroplacental ratio. How much baby blood is going to its head versus how much of the baby's blood is going to its placenta. And if you're taking too much to the head and not enough to the placenta, that suggests high resistances in the fetal tree and asymmetric sparing of the head. Once again, these are related to chronic maternal underperfusion. These are chronic features. They're not related to an acute adverse event. So usually these are, and in general, I'll tell you a general principle. When we're dealing, so far everything we spoke about are chronic features, and chronic features are usually good for antepartum monitoring. And when you start to look for acute features, that's when you start to get into intrapartum monitoring, because labor and delivery is a risk for asphyxia. But I'll clarify that more. So another kind of monitoring that we could do on the baby is something called a biophysical profile. And it's a complex test that involves many components. We look at fetal movement. Once again, if the baby's healthy and doing well, he'll have good movement. But now it's a complex measurement, because now we're looking both for chronic perfusion, but also we're looking more for like acute events too, because if there was an acute event and if the baby's becoming hypoxic or asphyxiated, then movement will go down. Muscle tone. We look at amniotic fluid volume. And the reason we look at amniotic fluid volume, that's a very chronic feature. It's part of the biophysical profile. And it's the only really, truly pure chronic thing in the biophysical profile. And amniotic fluid volume tells you the volume of amniotic fluid within the amniotic sac here. And the reason babies with severe IUGR or progressive IUGR, when the IUGR is serious, so there's not enough maternal supply, they start to get something called oligohydramnios, which means decreased amniotic fluid. And the reason is that the babies preferentially supply their brain, yes, at the expense of the placenta, but also at the expense of other organs such as the gut and kidney. So you actually find, if you were to, for example, do experiments in sheep, you find high resistances within the renal arteries and low resistances in the brain, so the baby is undergoing this vascular redistribution. Amniotic fluid is mainly made by the urine that the baby makes. It's sterile urine that's made in utero. It's sort of a different type of urine that's made during the fetal era, and that's what maintains this amniotic fluid environment. And so if you have underperfusion to the kidneys, you get oligohydramnios, or decreased amniotic fluid, and that could be a measure of chronic underperfusion, and once again tell you that you have IUGR, intrauterine growth restriction, which would be secondary to chronic maternal underperfusion. And the way they do it is the ultrasonographer looks and counts and sees how much, what the size of these amniotic fluid pockets that they could find, pure amniotic fluid pockets without having any fetal parts intruding into them. So that is part of what's called the biophysical profile. Now, the last part of the biophysical profile is something called a non-stress test. And I'm going to simplify this. A non-stress test is you're looking at the baby's heart rate. So when the baby starts to become hypoxic, so now this is clearly not a chronic feature, this is a more acute feature. When the baby starts to become hypoxic, the heart here of the baby is affected by hypoxia, and the baby's heart could become here. We're looking at the heart rate. You're literally measuring the rate of the heart. So beat, 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 beat. You could literally just measure it like this. And when the rate starts to go down, we call that fetal bradycardia. And that's what the baby does in response to hypoxia. So I'm not going to do a session now on fetal heart rate monitoring, and I wouldn't be the right person to do it. But let me just say something very simple to you. In acute hypoxia for a baby, if the baby's heart rate is here, you'll get a bradycardia. And that's, and so the heart rate goes down. If there's chronic hypoxia or chronic asphyxia, another thing happens too. usually babies' heart rates vary, so it'll be 160, 155, 160, 155, 152, 153, and we call this beat-to-beat variability. The baby's heart's not static, it jumps around a little bit. In chronic hypoxia, after the serious insult, and it has to do with the effect on the myocardium of the heart and also brain effects, because the brain controls heart rate a little bit, it allows it to be variable through the vagus nerve. If there's chronic hypoxia or ongoing hypoxia, you lose this variability. You lose this beat-to-beat variability, and you get what's called a non-variable fetal heart rate. So now, I'm not going to go into too much detail on the monitoring now, but one of the main notions that obstetricians have is that any time the uterus contracts, which it starts to do more and more and more as we go further and further into pregnancy, that's a stress for the baby because it cuts off some of the maternal supply to the placenta. Now, especially in the context, so the question is, so if the uterus contracts and that deprives the placenta of blood, and the baby starts to show decrease in heart rate or bradycardia, that suggests that the baby is hypoxic. And the uterus contracting is sort of like a stress to the baby, and it's sort of like what we do with adults when we put them on an exercise treadmill test. And there's this main concept in obstetrics that how badly a baby responds to asphyxia during labor is partially a consequence of what the chronic status of the placenta as a whole is. So if you have a good placenta that's nice and big and that's well supplied with well remodeled spiral arteries, a little bit of uterine contractions won't bother the baby. If you have a placenta that's already partially occluded, then a little bit of uterine, or partially underperfused, a little bit of uterine occlusion during labor will really upset the baby because the baby's already compromised, and then you'll start to see these hypoxic decelerations in the fetal heart rate. This was a very popular term, and in cardiology too, and that was a notion that you have partial vascular compromise through partial occlusion of a coronary artery, in other words, a stable angina, and you put the patient on an exercise treadmill stress test and you increase their demand, and then you bring out the strain. So by doing an exercise treadmill stress test, you're not only looking at the acute strain, you're also getting a sense of the chronic but sort of subclinical insufficiency. And that notion was important in obstetrics, and it led them to start to do something called a contraction stress test. And mothers were given oxytocin to make the uterus contract, and the obstetricians would look and see, did you get this deceleration? And that was said to be a test. It's almost like an exercise treadmill stress test of the baby, and it was a test of placental reserve. But because it involved administering a drug to the mother, and because even though it was very safe by what the epidemiology says, it would be better not to do that. And so what they start to realize is, just like it's good to have a heart that doesn't decelerate a baby heart that doesn't decelerate when you stress it, it's also good to have a baby's heart that accelerates when it needs to. And so if you monitor a baby's heart over time, what you'll find is if the baby's not sleeping, the baby will start to move. And when the baby moves, something great happens. Just like when I start to run, if I do exercise, my heart rate goes up. And that's a sign of good health. So they stopped doing the contraction stress test looking for the decels, and they just started watching babies and hoping that they move, and coupling it with ultrasound to see if they move, and looking for accelerations, and that became, you guessed it, the non-stress test. And so that, once again, it's a measure of two things. It tells you conceptually how good the reserve of the placenta is, but also once the baby's failing to accelerate, that suggests that there's already some hypoxia or anoxia, that the baby's irritated already. So, and if you have a non-stress test that's non-reactive, then you have to do other further testing. So that's what I showed. So that's part of this biophysical profile. The normal is you have a fetal movement, and then boom, the fetal heart rate, which is variable, you see I've shown the variability, suddenly goes up. So that's another monitoring that we could do in utero, and antepartum to the fetus is a biophysical profile, and you want to score, ideally score out of 8, and you want 8 out of 8. If the score is, let's say, less than 6, you have to really seriously think of delivering the baby, and if the score is less than 6 out of 8, you have to start to think about delivering the baby, because then the baby, but before you would deliver the baby, you would do other tests to confirm. Because one of the things about the non-stress test, and it's, in my opinion, one of the most important components of the biophysical profile, one of the things about the non-stress test is that it has good specificity, but it has good sensitivity, but poor specificity. And the reason is because you'll get false positives, for example, if the baby is sleeping. So you don't always get this reactive change. So in other words, it could give you it could give you false positives. And the reason we tolerate false positives is because it's used as a screening test, and what we're really trying to do is prevent intrauterine fetal demise. So we don't mind having a few false positives. What we don't want are false negatives. So therefore, that's the biophysical profile, and here I just speak about the other monitoring here. So the next one I already mentioned it, is the contraction stimulation test, where we give the mother oxytocin, we have the uterus contract, that makes the baby become hypoxic, and we want to make sure that there's no deceleration. This is worse than a non-reactive, non-stress test. If you have this, which we don't really do this test much more anymore, but if you have a positive contraction stress test with a deceleration, that means that the baby's at risk of becoming hypoxic, and you may have to think about doing something like induction. I'm not saying it's an indication for induction, I'm saying you really have to seriously worry about that pregnancy. So, but both of these tests, the biophysical profile and the contraction stimulation test, or the contraction stress test, are still antepartum tests, because you're not doing it while the mother's in labor. You're doing it to find out how well the baby is doing before the mother is in labor. When the mother goes into labor, we could do fetal heart rate monitoring, and we basically put a monitor on the mother's tummy. You could do it continuously, you could do it by intermittent auscultation. I don't want to get into the detailed obstetrics, and what you want is a good fetal heart rate that's variable. You do not want late decelerations, and I'm not going to really go into that biology now, but you don't want a fetal bradycardia, because a fetal bradycardia, especially a sustained bradycardia, if this is a uterus contraction, this is the bradycardia, a sustained bradycardia is not good, because it could cause fetal hypotension, and fetal hypotension is what causes injury. And so if you have sustained either deep, severe, intermediate decelerations, and I don't really want to define that, or late decelerations, then you have to worry about delivering the baby, because the baby could be hypoxic or asphyxiated. So this is not a test. Fetal heart rate monitoring during labor is not a test of growth restriction. It is a test of hypoxia or asphyxia. I'm not saying that it's a great test, and I'm not saying that it correlates well, and I'm not even saying that there's necessarily even proven benefit for continuous fetal heart rate monitoring. But the test itself is designed to be a test of hypoxia or asphyxia, and therefore to give you a sense of, at some point, do I need to do a cesarean section? The other thing that you could do, as another test of asphyxia or hypoxia, is when the baby is delivered, you have access to the umbilical cord. And you could take blood from the umbilical cord, and you could look at the cord pH. Because if there's hypoxia, you start to get a lactic acidosis, so the pH goes down, and and the lactic acidosis is reflected by a test called the base excess test. So acidosis and high base excess tells you that the baby is hypoxic. And because the baby is hypoxic, the blood within the umbilical artery has a too low pH. It has too many protons in it, because it couldn't exchange, it couldn't get rid of them, because the flow was cut off, or the exchange was cut off, and also you have this base excess that suggests a lactic acidosis. So these are features not of chronic growth restriction, these are features of actually tissue hypoxia and tissue acidosis, and that's, you would measure the cord pH. So this is sort of an intrapartum, or even postpartum, because you would have access to the umbilical cord after the baby is born. And then there's other labs and newer tests, like for example, we could do even fetal ECGs now. They do them in Europe because it's better than actual fetal heart rate monitoring. Other tests that we have is now we could look at angiogenic factors early for growth restriction. Some people look at other fetal parameters like fetal liver enzymes, because if you have, fetal asphyxia, so poor, let's say the events would be, fetal bradycardia, which leads to hypotension, then you have liver underperfusion, you could get elevated liver enzymes. So you don't only need to look at the cord pH and base excess, you could also look at other signs of hypoxia-induced damage in the fetal body. So once again, I know this was a little bit involved, and I know it was a little bit convoluted, but I just wanted to introduce some of the themes, and we'll keep repeating this, and ultimately the repetition will lead to the emergence of a narrative. Thank you so much.